Perhaps the most daunting challenge of a symposium of this kind is to give the closing keynote. Dr. Tony Iton is as perfectly situated as anyone could be to sew many threads together. He is a public health official, a physician, a lawyer. He has worked in a variety of settings. Currently, he's the Senior Vice President for Healthy Communities at the California Endowment. Before that, he was the Chief Health Officer at Alameda County in California, where he developed a model public health system that on the ground aimed at dealing with the very issues that we have been spending the last 8 hours talking about. Before that, he worked in Stanford, Connecticut, in San Francisco. He's a graduate of McGill University. He got his law degree at Berkeley and his medical degree here in Baltimore at Johns Hopkins University. The work and focus of the California Endowment, and particularly the Healthy Communities program, is all about dealing with issues of race, income, class, education, geography, employment as it relates to health status. And so thank you for giving this final presentation today, tackling the root causes of health disparities.
Thank you very much. Well, good afternoon. It's been a long day. I've got to say that I was born in Baltimore at Johns Hopkins Hospital, and I also went to medical school here. And when I left here in 1989, I kind of thought that my days of sitting in dark auditoriums listening to lecturer after lecturer were long behind me. And this brought back some real flashbacks from medical school. And I looked through the program and I counted, and I think I'm the 30th person to speak to you today. So I just have to salute you all for having the endurance to sit through, albeit in incredibly erudite presentations, but just the amount of information and conversation and the idea flow is sort of mind-boggling to me. I'm a practitioner. I've always been the kind of person that just kind of got antsy and bored just listening to theory, and I always needed to roll up my sleeves and kind of throw in and do something. So it's a privilege to be able to try to close this out from the perspective of a practitioner. Before I start, I want to really salute Dr. Blum for what he's done in a relatively short period of time in maintaining this symposium. I understand that it's evolved substantially from last year, which was much more heavily academic, and investing the community in this conversation is critical to this work, and as you'll see from some of the work that we're doing here, and certainly investing the students and the vigor and sort of insistence of youth is critical to this work as well, which I'll talk about. I also want to acknowledge Michael Scott, who's been acknowledged already, and he's been involved in Place Matters work here in Baltimore. And because Baltimore has always been dear to my heart, being my birthplace, I've always been very keenly interested in what's happening in Baltimore, and I'm very proud to see the work, and certainly the conversations today reflect an incredible amount of focus on trying to find solutions in this work. It's always a privilege to be on a panel or on a stage that Michael Marmot has graced. I will say that he really is the grandfather of this work. Sorry for inferring that you're not quite as young as you used to be. Another person that I want to acknowledge is a gentleman by the name of Len Syme, who's at UC Berkeley, who was one of my mentors and was a colleague also of Dr. Marmot's. And he was the one who first sort of opened up my mind to the possibility of doing this work. So I'm just going to jump right into this. I'm a lawyer as well as a doctor, so we lawyers always state our conclusions up front because we're afraid we're going to be cut off by a judge or something. So you have to get your conclusions out there. And by the way, that's a great recipe for giving good sound bites. If you spend a lot of time talking to the press, say what your bottom line is first and then argue back from that. The press loves that. So this is my most important conclusion. Health is political, and it's a small p for a purpose. It's not partisan, Republican, Democrat. Health is political, and when you look at a definition of politics as being the struggle over the allocation of scarce and precious social goods. So what's critical in that definition is it's a struggle. There's a product that comes out of that struggle, and that is an allocation decision over scarce and precious social goods. And when we're talking about scarce and precious social goods in health, we're not talking about esoteric things. We're talking about things like a park or a grocery store. And understanding that allows you to understand the kind of practice that we need to develop to actually undo some of the inequity that exists in our society. Another conclusion, and this is sort of just a kind of a catchy way of saying it, does your zip code matter more than your genetic code? And we say this because we want to encourage people to think differently. We want to change the narrative about what brings about health in a community. There's also a central question for public health practitioners, and that is, how committed are we to the principles of social justice? Because there's a lot of rhetoric about health disparities, health equity, a lot of conferences, a lot of publications, but is there true commitment to actually engaging in the work of social justice? Well, what is social justice? Well, when we try to translate that into practice, you recognize, and I actually find it kind of difficult. I looked up social justice, and you get these 3-page definitions. The one thing I can distill from social justice is that there's an element of truth in social justice, and that's what we're really good at in public health. We are excellent at having seminars on the facts and on the data and on the policy prescriptions. And that's good, that's critical. The truth is what we do in public health. We are expert at the truth. But we can't stop there because social justice is also about power. And if we just leave it at truth, we haven't done enough. We have to think about how do we organize, how do we bring people together, the people that are most impacted by the inequity? How do we enlist them to participate in crafting the solutions? How do we listen to their prioritization for what is important in their lives? That's critical, and we do that very poorly. So if we're really about social justice, we have to understand power, how it works, we have to invest in it. So I'm going to talk you through a framework. It's called the Bar-High Framework, which is the Bay Area Regional Health Inequities Initiative, which was really the product of a group of frustrated public health practitioners who felt like the challenges that we were facing in our work were much greater than the tools that we had at our disposal. So we needed to come up with new tools. And to figure out what those new tools were, we had to design a framework that allowed us to essentially spread out the opportunities for intervention and look where we could have some leverageable opportunities. And I'll explain to you what that means. I'm going to talk to you about the power arc, which is absolutely critical to this work, and it was alluded to in one of the earlier panels. Okay, so again, I'm stating my conclusions up front in case some of you want to go to sleep or, talk on the phone. I don't know what you do these days. Our work is really about 3 things. It's about changing the narrative in health. It's about policy advocacy and busting down silos, trying to get the butcher, the baker, and the candlestick maker all to work together. And then finally, it's about building power in place, in community, to change the status quo power dynamics in a community. And the way I've outlined this presentation is I talk about the truth, and I have much less truth unveiling to do because this whole day has been about truth. But first we have to find the truth, then we have to try to gain some understanding, distill meaning from that truth. And once we're comfortable with what the meaning of that truth is, then we have to find a way forward, and that's the practice. And that's what I'm going to talk about. So why does place matter? Well, I grew up in a very, very nice place. I grew up in Montreal, Canada, having been born in Baltimore, and my father was a graduate student right here in the 1960s, and I was born while he was here doing his PhD. And then he promptly moved back to Canada with my mother, and I grew up in Canada. And I grew up in Montreal, Canada, and my father taught at McGill University. And Montreal was a beautiful place in the 1960s and 70s, and it still is to this day. It was a wonderful place to grow up. It's a cosmopolitan city. It's safe. It's visually beautiful. It's full of art and music and multicultural. It's an old volcano that's in the middle of the St. Lawrence River that if you go up to the top of the mountain, you can oversee the entire city. In fact, that's what this view is here. This is a view overlooking McGill University from Mount Royal. When I was 22, I left Montreal to go back to Baltimore and ended up at Johns Hopkins Medical School and was delighted to be here. But I didn't know Baltimore like my parents did. My parents talked about Baltimore like this wonderful place. When I saw Baltimore, this is what I saw. And in fact, I was being toured around Baltimore by an upperclassman, East Baltimore. And I was in shock. I literally didn't know what I was seeing. And I said to this guy who was driving me around, I said, when was there a war here? In my mind, I had no frame of reference for this. To me, this was the mid-'80s. This looked like Beirut, which was in the news at the time. You know, you had blown-out apartments and these mangy dogs running around, cars up on jacks. I couldn't understand what I was seeing. And he said something to me that I'll never forget. He said to me, and he turned around with his look of disdain in his face, and he said, what do you expect? It's the inner city. And I thought, what do I expect? You mean there are people that expect this? This is a norm? This is okay? And you've got a name for it. You call it the inner city. It's literally like an abscess that walls off society's troubles that people just avoid. And I should expect it. That's what he told me. Well, the rest of my career has been dedicated to trying to undo this and to understand the implications of this on the health of young people and families. And I look at a kid growing up in East Baltimore and I say, there, but for the will of God, Allah, whomever, go I. And what would I have been like had I grown up in East Baltimore? And I wanted to go back. I came a day early because I wanted to see East Baltimore again. I wanted to see if it had changed, and it has changed. It's gotten better. But I could still find this. This was yesterday, driving around East Baltimore. Other than probably Detroit, I think East Baltimore's got to have sort of the record for boarded up buildings. I just don't understand how you can have so many boarded up buildings with people living in and amongst it. The impact of that on people's sense of purpose, their sense of agency, their sense of being valued in society, that is profound. Okay, so finding the truth. Well, I want to show you just quickly, because we've spent a lot of time doing this already. This is the San Francisco Bay Area where I live now. That's San Francisco. This is Alameda County where I was the health officer. It's kind of shaped like a boot that is very much interested in crushing San Francisco. And you can take death certificates, which I was the health officer. And when you're the health officer, and I'm a data junkie. So when you're the health officer, you're the registrar of all births and deaths. So you get you have the ability to have this comprehensive data set and to analyze it. And you can tell from a death certificate how old somebody was when they died, where they lived, what their race, ethnicity was, what they died of. And you can take those 4 data points and absolutely characterize death in a place. And so we took 400,000 death certificates, put them into a database, and then we mapped them. And so this is the boot. And these are the census tracts in the boot. There are about 150 of them, about 10,000 people in each one. And we looked at the life expectancy. And I had the most brilliant epidemiologist from UC Berkeley who told me that this would be a waste of my time. I shouldn't do it. It will look like a Christmas tree. Death is random. Well, they were wrong. And I knew they were wrong because I'd been in East Baltimore. And I said, there is no way that community doesn't impact people's health and life expectancy. And in Alameda County, we have parts of Oakland and elsewhere that are not quite as bad, but similar in the sense that there's concentrated disadvantage. And you can map it. And using this, we started to say to people, give me your address, I'll tell you how long you're going to live. And I can do it. I mean, it's not because I'm brilliant. It's because of the way we pattern opportunity in this society. Your address says way more about you than you know. And actually, there are advertisers and marketers that know this as well. It's not just Alameda County, you know this. This is Seattle, King County. We went up and did it up there. I had to come back to Baltimore, went to the Baltimore City Health Department, asked them to do this analysis. They did it. More recently, and Michael's involved in this, they published a very excellent report, their Place Matters team looking at health equity, and they have some census tracts in Baltimore, in this city, where life expectancy is in the 50s. This is Los Angeles County. This is Cuyahoga County, Cleveland, which previously was the city with the greatest disparity that we had found. There's a community in East Cleveland called Huff with a life expectancy of 64 years. Just down the street, there's Lyndhurst that is approaching 90 years. And at this point, we still try to explain this disparity by saying it's a product of a lack of access to health care and poor health behaviors. And I say to you that that is a lack of critical thinking. We're smarter than this. We know more than this. We have to stop coming up with these lame explanations for a phenomenon that is so profound and embedded in the very structure of our society. This is something that Robert Wood Johnson Foundation did by looking at, and Sir Michael Marmot talked a little bit about this. You can predict how long somebody will live based on the stop they get off on the Philadelphia Metro line. So you can take life expectancy and go to the census and get poverty data, and you can correlate those two things, and you get this crude social gradient. We wish we were in Great Britain, where we could actually get individual level social status data. We can't do that here, so we have to use proxies. We use the proxy basically of neighborhood, and this is the cost of living in a poor neighborhood measured in premature death. This is the true death tax. As you move from left to right here, you're going from relatively wealthy to relatively poor neighborhoods, and you see life gets shorter. We did this for the Bay Area, and we did this for the state of California as a whole. And in the Bay Area, you can actually monetize the slope of that line and tell people that every additional $12,500 in household income buys you a year of life. And I jokingly tell people that this is the kind of data they should bring when they're negotiating their next raise. Okay, so we know, and we've heard from a number of speakers today, that our health here is not good. It's not only bad for low-income people, it's actually bad for middle-income people, and it's relatively bad for wealthy people. This was the Institute of Medicine published this report called Shorter Lives, Poorer Health this year with the National Research Council, looking at the U.S. across a range of health measures compared to 17 peer countries, mostly European. And this was their conclusion. The panel was struck by the gravity of its findings. For many years, Americans have been dying at younger ages than people in almost all other high-income countries. This disadvantage has been getting worse for 3 decades, especially amongst women. They go on to say the U.S. health disadvantage cannot be fully explained by the health disparities that exist among people who are uninsured or poor. As important as these health issues are, several studies are now suggesting that even advantaged Americans, those who are white, insured, college-educated, or upper income, are in worse health than similar individuals in other countries. Okay, so that's the truth. What does this mean? What can we distill from this in terms of how this is operating in people's lives? How is the neighborhood or the community or the stressors getting underneath the skin? Well, we know this because we're at Johns Hopkins and we know about allostasis and the allostatic load. We know about stressors, and we know about the fact that there are mechanisms that the body uses to essentially interpret stress and changes our very physiology. I'm not going to spend a lot of time on that. You all know this because you're all good medical students about the pathways from stressor to release of stress hormones. We also know that acute stress hormones are actually good for us. They help us make very good decisions when we're facing sort of life and death circumstances. But over time, chronically, they actually almost do the exact opposite. You know, they essentially weather our body. They prematurely age many of our core systems. So we know when we're looking at health disparities, we're only looking at the tip of the iceberg, and that beneath the surface there's a whole host of social disparities that are man-made. And I often like to say will probably be unmade by the work of women. Okay, so let me take you to the practitioner's framework. So The traditional framework is the medical model, which you start reading from the far right, and it says premature death is essentially a product of premature burdens of disease and injury, which are a product of bad behaviors and risk. And so the real variables that we have at our control are what people know, trying to change their individual knowledge, trying to change their genes to the extent that we can, and trying to improve their access to healthcare. And this is what our group in the Bay Area became frustrated about. It was like, well, those tools are too limited to deal with something like abandoned lots that are essentially hazards to young children playing in low-income neighborhoods. So we built out this model, and we started to think, okay, so, and let me just say that every time I present this somewhere, particularly amongst academics, somebody comes up to me afterwards and says, shouldn't that arrow be going this way? Or shouldn't there be two arrows going this way and then another one doubling back? This is not trying to explain the universe. This is a framework just trying to pull apart opportunities to intervene. That's all it is, and it's very useful for that purpose. So we call the upstream model the socio-ecologic, and we talk about social inequities, which manifest themselves in any number of different ways, including in the East Baltimores and the East Oaklands and the East Clevelands, where people are systematically deprived of the whole swath of health protective resources. Why is that? Because of a set of institutional decisions, policies and practices that essentially steer resources disproportionately to favored populations. Why is that? Well, because historically in this country there have been essentially a set of codes which defined valuable populations and less valuable populations, and those are isms. It may be race, it may be class, it may be gender, it may be immigration status, it may be sexual orientation, disability status. Those statuses define your relative value and set policies that either favored or disfavored you. And so we're looking for, okay, so what are the opportunities to look at intervening? The world of health disparities is downstream. The world of health inequities is upstream. You can take health out. It's just inequities produce disparities. And if you're a simple-minded person like me, you talk about conditions producing consequences. I still practice internal medicine. I spend most of my day practicing internal medicine in the business of consequence management. Sometimes I refer to it as damage control. And I'd like to get out of that business. I'd like to get to the conditions and start changing those conditions to reduce the burden on the healthcare delivery system. You can actually change the downstream outcomes to school absence and truancy leading to grade failure, leading to dropout. It doesn't matter. The upstream ones stay the same. So we argue, let's focus on the interventions upstream, which is not to say that the downstream ones don't matter. They do matter. They're necessary, but they're not sufficient to really deliver health, particularly at the community level. So we've simplified this practice into looking at place, looking at policy, and looking at narrative. And then ultimately, we want to enlist the participation of the people that are most impacted, people who have been stigmatized by racism, by classism, by sexism, the people who are feeling the pain, the rage, the insult, the hopelessness of living in these conditions. We want to organize them. We want to empower them with tools to participate in policy making and resetting the policy agenda according to their priorities. That's critical. We can't do this for people. Very simply, the medical model says behavior drives disease, drives death. The socio-ecological model says that there are a set of biased societal behaviors, or isms, that produce a set of policies and practices which are present day and also have a legacy of prior practices that produce neglected communities, amongst other things. And we have a practice to prevent death. We call it emergency rooms. We have a practice to prevent disease. We call it clinics. We have a practice to prevent or change behavior. We call it health education. We need a practice to address neglected communities. You heard about some of that from our philanthropic partners and also from some of our government partners that are struggling to develop this practice, that are constrained politically, they're constrained by resources. We're lucky, and I'll tell you why, we don't have some of those constraints. So we're trying to figure out what does the comprehensive practice look like, and we're trying to share this far and wide, and we're trying to influence government institutions to adopt some of this practice. In neglected communities, we call it building power in place. We think that that's not sufficient. We have to look at policies and practices. We call that policy advocacy, and again, silo busting. And then finally, looking at these belief systems. And if I had more time, I would show you the clip of Mitt Romney and Newt Gingrich talking about essentially low-income people living in poor neighborhoods and what they think their problem is. They're establishing a narrative. And once people accept that narrative, the policies that flow from that narrative are consistent with that narrative. So if we want to change the policies, we have to change the narrative. And people who are thoughtful people, I don't know why we do this, we go right to policy and we ignore narrative for some reason. We don't talk about the overarching stories, but we have to. And so part of our practice is about changing the narrative. Okay, so what does that look like? Well, I'm lucky enough to work at a foundation that has decided to put $1 billion on the table over the next 10 years, betting that we can improve the health of 14 low-income communities that are ravaged by health disparities in California more effectively by investing in the social determinants of health than we could if we put that $1 billion into health care. And that's what building healthy communities is about. And we don't know how to do it, but we have a rough guesstimate of what makes sense. Okay, so building healthy communities is really about, there are 14 low-income communities across the state that we're investing in. We recognize that human capital, and thank you for having a panel on human capital is our greatest resource. We waste so much potential every minute of every day in these communities, and it's to our collective disadvantage. Kids that are smart, kids that are talented, kids that are creative, they don't get an opportunity to express that, and we don't get the benefit of that. We need to invest in those communities to build that human capital. And it's not about beating the odds, it's about changing the odds. Everybody has a story about somebody who grew up in a low-income community and ducked bullets every day and then, was attacked by wild dogs on the way to school, and now they're the president of Xerox, and if that person can do it, then anybody can do it. That is not true. That person was an exceptional person who beat the odds. Our goal is to make it easier for more people to do that. 4 key systems in every community: health systems, the human service systems, which include the criminal justice system, the land use systems, and the schools. And then critically important, and this is where the foundations I think can really be helpful in Baltimore, is creating that collaborative table. Creating it, staffing it, funding it. We're doing that in each of our 14 places for 10 years. And that's a table where the school superintendent can be at, the police chief, the health director, community members, community-based organizations, to hash out common purpose over time. Not just around a grant, not just because 2 of them happen to be friends, but to really change the way that we operate, because we have an enormous amount of fragmentation in our society, particularly amongst the so-called experts, and we don't routinely work together. Okay, very quickly, building power. We need to build a critical mass of social, political, and economic power amongst the residents of these low-income communities so they can effectively participate. We live in a democracy. Things change by participation, so that they can effectively participate in setting a new agenda for their community. So that's what we're doing. We're organizing. We're spending $100 million on organizing in California, just hiring community organizers to go door to door to invite people to participate in this effort to change their communities. And I encourage all foundations and government to think about either funding or partnering with organizing. You can't do this just with policy, smart people figuring out what the best policy is. You actually have to get people where they live and have them participate in changing that agenda. Policy advocacy. This is an example of one of our campaigns that we call Health Happens in Neighborhoods. We're looking to develop health-promoting land use strategies, joint use strategies, so school buildings are not mothballed in summers or at nights. They can be used as parks and recreational facilities for communities during those times. Walkability, bikeability, a whole list of things that you are probably recognize as not being all that outrageously new, but in many of our communities, these things don't exist. I want to talk just very quickly about grocery stores. Supermarkets. Food deserts is a big issue in our state. We decided, and this is something I did not know could happen, but when you're at a foundation, you can just put up money and say, hey, I want to start a fund. We're going to put some money into it. Who wants to join it? And one of the things I've learned is that money loves money. and that nobody wants to be the first one in, but everybody wants to be the second one in. I don't know what that is some aspect of human nature. So we put $30 million into a fund, and we said this fund is going to build grocery stores in low-income communities. We needed about $200 million to build all the grocery stores we thought we would need in our 14 places. Within 18 months, we raised $300 million to build grocery stores. And the partners there are, Wells Fargo, Bank of America, Kaiser, a whole bunch, Citibank, who just said, look, we'll do it if it pays us a return on our investment. And because we can take the first risk, we're protecting their capital, and their capital is investing in building these socially important assets in communities. I didn't know that you could do that, but apparently you can. Changing the narrative. Changing the narrative is a combination of new messages and new messengers. We have to actually bring to the fore people who actually have real experience living in communities and amplify their message. So when we worked with Baltimore, we told them, look, if you do this analysis, as happened with us, this is going to be on the front page of the Baltimore Sun. It was on the front page of the Baltimore Sun. You've got to be ready to essentially move into that moment and develop that message. What is the narrative you want around this work? What is explaining these disparities? And they were brilliantly prepared to do that. We spent a lot of time getting this into the front page of newspapers all over the country. This was a series that ran in the San Francisco Bay Area that ultimately won the Edgar Allan Poe Award at the White House Correspondents Association. So these reporters actually really love me now because I got to meet President Obama and get an award from him. And now they're writing a book about this work. And what's unique about this is that it's a radical sort of rethinking of what actually causes health in communities, which is not to say that health care doesn't matter. It's just to say that it is necessary, insufficient, and it is stressed to the point of breaking. Some of you have seen Unnatural Causes. No doubt this is now actually part of curricula in most public health, or many public health schools. If it's not here, which I imagine you probably have, it's a powerful tool. Recently, we partnered with HBO and the Institute of Medicine to produce Weight of the Nation, which looked at the whole spectrum of science behind the obesity epidemic, but as well the community level disparities and the work that needs to happen at the community level. I encourage you to take a look at that as well. We at the California Endowment have been advertising this sort of far and wide. Some of you probably have seen some of these, I hope, if you went to APHA this past year, talking about the disparity in life expectancy by zip code and the disparity in high school graduation rates. We put this up in the new terminal at the Sacramento airport, where all the legislators walk by on their way to and from their districts. We know that they see it because they call me, and they want to know why I'm reducing property values in their districts. If you were at APHA, you saw that we literally festooned the Metreon building in San Francisco with these images, because people don't know this. And when they see it, they're really kind of, they're struck by it. What? That much difference? Why is that? And that's our opportunity to start talking about what health really is. So our campaign is called Health Happens Here. We focused on neighborhoods, schools, and the healthcare delivery system. This is the recipe, and I'm going to wind up with this. You have to build power. You have to focus on the people that are most impacted. There is no other way to do that. There's no other way then but to do that. And when I've seen this fail, it's because this wasn't done. We haven't changed the power dynamics in communities. You have to. There's no other way. We live in a democracy. Politics matter. This is about participation. This is about enfranchisement. This is about meaningful input, not just having a focus group. But that is not enough. You also have to foster this collaborative efficacy, or break down the silos between these various different fragmented castles of expertise, including this one, Johns Hopkins. And I'm really appreciative of the dean for opening up the walls and bringing in a wide variety of sectors that can think meaningfully and be held accountable to finding common purpose. But that's not enough. You actually have to invest in youth leadership, like some of the panel members we saw up here today. I like to say that there's no revolution in the history of mankind that has been led by old people. I've been challenged on that before, but most of them have been led by the young because they're not used to sort of accepting defeat. They don't know what they don't know, and they have passion, and they have the right to demand accountability from us, the older generation, and they're the fuel that drives these kinds of changes. But that's not enough. You have to leverage partnerships. You actually have to go to Bank of America and say, you're investing, you've got Community Reinvestment Act obligations in this community. What are you doing with them? Can we leverage them? Can we direct them to grocery stores? Can we direct them to child care facilities? Can we direct them to parks? And then push them to work with you to improve these communities. That's not enough yet. You still have to change that narrative. This is one of the most important aspects of this work. It's not about the policy. Don't go right to the policy. Go to the narrative. Tell the story. That's how people learn. That's how policymakers learn. That's how the general public learn. That's how the silent majority understands these issues. They have to dovetail with the narrative first before you can take them along the journey towards policy and results. And we think that's the recipe for building healthy communities. And we're doing it. We're betting $1 billion. And I will personally be the laughing stock of the public health world if it fails miserably, but I will go down in a blaze of glory. It's about power, it's about policy, and it's about narrative. And that's what we think we need to do. Thank you very much.
Tony, thank you.